Thank you so much. It's great to be here today, and it's such an honor to meet with you all. And I'm really excited to tell you a little bit about what the children in the Philadelphia area are teaching us about concussion. And so I don't have any disclosures. I aspire to have some disclosures. But hopefully what we'll tell you a little bit about today is what we're learning about concussions from our kids in the Philadelphia area. We are always trying to figure out how we can do better in terms of diagnosing and managing and getting our kids back to play. And how are we doing that now? How have we changed over the years, and what is new coming down the pike with some of the research that we're doing? So hopefully we'll cover a little bit of that. Our outreach team is really excited that I'm here, and so they wanted to make sure that I share greetings from Philadelphia, and they said that they were going to tweet this week somehow, so we'll see if you guys see that on there. But as Mark said, we do see a lot of concussions in our program at our hospital. It is an entire network across 3 states. We have basically everything from the emergency room to primary care doctors to sports medicine specialists. I'm in the sports medicine group, which is under the pediatric orthopedic department. But you can see we get kids that come through everywhere, ER, primary care, and sports. And we have tried to do a lot to actually train our ER and primary care doctors using our electronic medical record to give them clinical decision support, because we know they see a lot of things. And so we've basically tried to develop a lot of the tools that we have here, translate them into something that would be feasible and usable for them in that setting as well. And then we also extend then to our PT, OT, and speech therapists as well. So we're really, really fortunate to have a lot of and take care of across the network that way. And so our question is, where are we with the diagnosis of concussion? And as you all know, I'm preaching the choir here. We're still really at subjective symptoms by and large for the most part, right? And so from that perspective, what can we learn and understand in terms of symptoms in kids? You all know the standard, concussion symptom scales. There's a whole variety of them out there. The PCSS or the PCSI. We use the PCSI, which is the post-concussion symptom inventory, because it does have a validated tool for 5 to 12-year-olds. And we do see kids that young in our practice with concussion. But as you can see with this, it could be a concussion, but it could be a whole host of other things, right? Are they pulling an all-nighter in college? Do they have mononucleosis? Do they break up with their girlfriend? Do they have a migraine? And the last few years could have been COVID. Absolutely, it could have been COVID. Or was it just a teenager? And so for any of you who have teenagers at home or work with them in the office, you know that this is really true, right? And so our colleague Grant Averson in Maine looked at 30,000 kids and found that up to a third of boys and girls actually qualified as having post-concussion syndrome, and they never had a concussion, right? So can we do a little bit better, from that standpoint? And so what if we ask a little bit more specifically about symptoms, right? So, obviously asking that symptom scale that we had up on the slide before is helpful, but what about if we ask about vision? And you'll realize that, our group and I are kind of a little bit obsessed with eyes, and you all may think, okay, she's a little weird, but that's okay. But we're really, really interested in sort of the vision deficits you have after concussion. And so we actually collaborate with optometrists, and they've done a bunch of studies where they looked at convergence insufficiency, which is the difficulty focusing near, and basically use this symptom scale that is really visually oriented. So it asks you questions like, do the words jump on the page? Do you skip lines when you read? Do you get tired when you read? Those kinds of visually specific symptoms. And so what we found with that was that kids who had a vision diagnosis associated with their concussion actually had more of these vision specific symptoms. But interestingly enough, if they did the concussion questionnaire at the same time, like it was the same visit, they actually didn't recognize that they had vision symptoms, right? So they had these vision symptoms if you asked them specifically about vision symptoms. They had these vision diagnoses, but they didn't actually recognize that they had it, because only 29% of them endorsed having vision problem on the PCSS. So again, we can do a little bit better in terms of how we ask the question. And so then, can we do something more than just symptoms? I mean, we're all clinicians, and we'd like to think that we have more tools in our toolbox, and we would like to think that we could actually use our clinical exam to try and figure some of these things out. And so we became really interested in what can we figure out, that we don't want to have the conversation always be, I think you have a concussion, but your exam looks normal. And so that has happened, for time immemorial, but hopefully not so much anymore. I'm sure none of you are. But we've been tinkering with this exam here, which will maybe look a little bit familiar to all of you as not being that dissimilar from the vestibular ocular motor screen, which Ann Muka and the Pittsburgh group published on. We've been tinkering with it on the other side of the state. So Pittsburgh is about 6 hours due west of Philadelphia. And so we've been tinkering with it in our office practice in terms of trying to figure out what's useful for us, what do we add, what do we change, and what seems to work for kids. And so we have a bunch of references there that certainly I'm happy also to share besides what's on the slides, that we have added convergence using a very specific convergence rule, which you can see there. And I actually brought one, and it's in my bag back there if you want to take a look at it. And it has a specific visual target that kids will tell us when it goes blurry and goes double. And then we also look at monocular accommodation where it goes blurry. And those are the cutoffs that we use based on basically population-based norms that our optometrists have done studies on. So that convergence greater than 6 is abnormal, and then the accommodation is age-related. So my accommodation, definitely worse than your accommodation. And so that's what we look for in the kids. With regard to the vestibular movements that we're looking at, smooth pursuit is something that we take a peek at. With saccades, we found that actually doing 20 repetitions was maximizing our sensitivity and specificity. That if we asked them to be able to do 30, some kids actually had some false positive, but the VOMS only has 10, and that definitely has a little bit of a ceiling effect, and a lot of kids who have concussions can do 10. And so we found that 20 worked best for us for both the saccades and the angular VOR. With regard to vestibular balance, my colleague, actually Matt Grady, developed this great task, which we really love because it's practical. We use it in the office. It's really quick to do. It's free. And we basically called it the complex tandem gait, but essentially it's 5 steps and 4 conditions. Eyes open forwards, eyes closed forwards, eyes open backwards, eyes closed backwards. And so there's a link to the video there that you can see on our website, but just so you can see here, just some examples. We'll have them sort of all run together here. Smooth pursuit, some VOR, and then that gal. The 2 kids on the left are all normal. And in saccades, VOR, smooth pursuit, complex tandem gait. In terms of what we see then in the office for a kid who's like injured, this is a kid who has concussion, and he's doing eyes opens forwards right now. Then he's going to do eyes closed. What's nice about the 4 conditions is that each condition is a little bit harder. It actually helps you with the ceiling effect, so that almost everybody can do it eyes open forward.
Close your eyes, keep going.
But the eyes closed backwards gets really hard, and actually sometimes we'll have parents, at this stage say, "Johnny, cut it out. We're at the doctor's office. Stop horsing around." Because they can't believe their child's balance is that off after a concussion, right? And if you don't do this, you don't know. And so we found it very, very useful. It takes, as you can see, total tops 2-3 minutes to do this entire evaluation. It's really handy to us in the office. So what do we find when we look for these deficits? And so in this study, we looked at 100 kids, and we found that actually there was a high rate of visual disturbances. And so saccadic dysfunction at 29%, accommodation deficits at 51%, and convergence insufficiency at 49%. Interestingly, you can also see that a lot of these kids had 2 or 3 of these, different deficits. And so from that perspective, it really does speak to the fact that what's going on in the brain is that it's the higher level function that's being affected in terms of integrating visual input and visual function. And so that's, it makes sense to clinicians who are seeing this, in the office on the sidelines. This is a guy who came to us in the summer after a American football practice, and he's trying to do vertical saccades here, and he's really just having a hard time coordinating. This is a young guy who saw 3 or 4 other clinicians before us and was always told that his vision was normal, even though he was complaining of vision problems. And part of the problem was because all we really do for screening is visual acuity, right? And so it's not common in a lot of general, medicine to check for eye movements. And so that's where, again, we would say we want to look a little bit more closely. And why is this important? In some of the work done by my junior colleague here, Dan Corwin, what we found was that our kids who have vestibular deficits just seem to have issues where they took longer to return to school, longer to return to sport, took longer to recover on some computerized neurocognitive testing that we would perform, and then also seemed to predict some persistent symptoms. And so that's, again, a little bit of the holy grail right now. When you come and you present to care, Are you going to be one of the people that's going to get better in a few days or a few weeks? Or are you going to be someone who's going to take, 3 weeks, 4 weeks, months? And so reseated near point of convergence, having symptom provocation on those visio-vestibular testing, dizziness, a premorbid history of anxiety, depression, and 3 or more concussions seem to predict a longer recovery. And what was interesting was that our kids who had 3 or more concussions had a higher prevalence of these deficits, so there might be a hint of a little bit of a dose effect there in terms of injury. And then we were interested in the relationship between the visual and vestibular, because even though they're different systems, they are related. And in this study, what we looked at was that these signs and symptoms actually appeared to fall into 2 different clusters. There was a vestibular cluster, where actually it wasn't just balance that was in the vestibular cluster, but also it was the VOR, smooth pursuit, and saccades, which, again, you could have thought maybe it was going to fall into the vision cluster, but those eye movements actually fell more under the vestibular cluster. And then the vision cluster made sense that it was in your point of convergence and accommodation amplitude. But then what was interesting, if you look at this figure, which is a little bit disorienting, so I apologize, but what the yellow is the presence of this of the sign or the symptom, and then the blue is the absence. If you look at the different clusters, the vestibular cluster, almost everybody has the vestibular cluster, but the yellow bar that goes all the way across are the people who have vestibular as well as vision deficits. And so it looks like the kids who have vision also have vestibular, and that's a subset of the kids who have vestibular issues. And so, again, kind of makes sense for all of you taking care of kids out there. They have kind of both and, not either or. And so I think that that's one thing that's interesting to us. And then in this study, what we found was that the smooth pursuit, VOR, and balance deficit predicted prolonged recovery beyond a month. And then the abnormal accommodation also did, but the near point of convergence didn't. And so along those lines, again, some things maybe to look for that might be helpful in terms of predicting who's going to take longer to recover. So what? Why do we care about this? She's interested in eyes, I'm interested in eyes, you're not interested in eyes, why do you care? I think it really does help us with our patients and our athletes in terms of helping them understand what can be a very bewildering injury. It's probably something that's not like anything they've had before, and so how do we help them feel like they have some self-efficacy, some agency, and not just having this really strange injury, act on them. And so hopefully by doing this assessment, it actually gives us a little bit of insight into what they're experiencing and how can we help them in terms of managing that. And so from that standpoint, we want them to be able to understand how to manage getting back to school, getting back to activities, and not sitting in a dark room forever and ever. You can't, your brain is a use it or lose it kind of organ, just like a muscle, even though it's not a muscle. And so the implications are in smooth pursuit, they're going to have trouble with a moving target. And so that could be an issue for ball sports, but also an issue for driving, right? And so we're doing some research in that area as well, because that's actually pretty dangerous as far as activities go that teenagers do. And then saccades, are jumping activities that are used in scanning. And so kids who have trouble with saccades on your exam are going to have trouble with reading if it's horizontal. If it's vertical, it's going to be taking notes, right? Looking at the monitor, looking back at the keyboard or notebook. So giving them some insight into that is sometimes helpful. The near point of convergence obviously is going to be really hard if you're going to be reading it near, at a near distance. And so that could be, a book or a tablet or a phone. There's a contribution from monocular accommodation. And so kids who have near point of convergence and accommodation issues can have blurry vision, loss of place, words moving on the page. What's interesting about accommodation, obviously, is that besides contributing to convergence, it's under autonomic control, right? And so then that gives you a little hint as to maybe what can we do to treat that. And so we'll get to that in just a second as well, because, we're always trying to make some connections in terms of what we're doing. And so some of the relevant accommodations we'll give our kids with regard to school, in particular with the visual, that they get extra time or untimed tasks, pacing breaks that are particularly visual pacing breaks. We'll talk about physical breaks and cognitive breaks, but in particular we'll talk to our kids about visual breaks as well. Pre-printed notes, large font, electronic, printed versus electronic format or audio format. And then again, the extra time in the hallways is sometimes helpful for all the VOR issues. And so then in the United States, we've been, our pediatric organization, the American Academy of Pediatrics, has been interested in trying to make sure that pediatricians are the most common place where kids are seen first after an injury. And we want them to be aware that they should be looking out for this. And again, how can they try and think about asking the right questions, maybe doing some kind of a screening examination, and then either giving supportive care or then referring on to a specialist as needed. And then what do we do, from a concussion standpoint? You'll recognize this from the consensus statement from Berlin, which is the update is delayed, and Margot's been a huge part of actually getting the next version out from Amsterdam, and that's been a huge amount of work. So hopefully there'll be an update next spring. But right now, we're not doing a whole lot early on, but there are some things that we have learned since 2017 that I think are really worth pointing out. And so first article that I want to highlight here is from our colleagues in the emergency department in the University of Wisconsin. So Danny Thomas and the ER there basically randomized kids either to a couple of days of rest or 5 days of rest. And then they just looked at how they did. And what they found was that the kids who rested a little bit longer actually had a longer outcome. They took longer to recover. So it is possible to have too much of a good thing, right? And so I think from that standpoint, more is not always better. And so 1 to 2 is sort of where I think lots of folks have landed in terms of a little bit of time where you have a break, you modify your activities, let your symptoms abate a bit, and then start ramping back up gradually. And then more recently, just last year, Magnow and Rebecca Mannix at Children's Hospital of Boston, so our colleagues up north, did a randomized controlled trial looking at screen time, and they randomized kids to screen time permitted or screen time abstained. You can see that they didn't really abstain. So basically the abstinence group had 130 minutes of screen time, even with the recommendation to refrain. But compared to their let them loose group, where they did 620 minutes of screen time, there was a difference there in terms of the kids who were told to restrict. And the screen time permitted group did take longer to recover. So they took 8 days versus 3.5 days. So again, probably about as good evidence as we're going to get that having a little bit of a break from the electronics is not a terrible thing those first couple of days. So you have a little bit of a foot to stand on when you're recommending that, and not just being like a mean, boomer or Gen X, in terms of what you're telling your kids out there, right? And so that's helpful. The other thing that we were really excited about then too is that there's active rehabilitation strategies for persistent symptoms, where essentially vestibular therapy, which many of you are going to be much more expert than I am in, is something that we'll do with kids if they have persisting symptoms. And the question really is, how early can we do it? And so we're still working on the answer to that, as are other folks in the group around the world. With regard to exercise and aerobic exercise, that was an open question. What's the timing of that? And we were really fortunate to be in a study where essentially what we found was that if you prescribed a heart rate targeted aerobic exercise prescription, which we always had to make very clear to our kids, this is not training, this is not sports training. This is a little bit of aerobic activity, right? And so that's really important, because if you, again, tell athletes, you can exercise, they're going to let her rip and then go on out there and exercise. And that probably isn't what is indicated in this early time frame. But in the study that was led by John Letty at Buffalo, also with Bill Meehan and Rebecca Mannix in Boston, and our group at Children's Hospital of Philadelphia, we found that kids were able to get an exercise prescription that was heart rate targeted, where they were allowed to have their symptoms go up by 1 or 2 points on the 10-point pain scale, but then stop. And if they did that every day for half an hour, starting in that first week, they actually recovered quicker than the kids who did not exercise. And they also had a lower likelihood of having persistent symptoms and not having problems a month out. In terms of cognitive issues, we don't commonly refer our kids to either speech therapy or occupational therapy. What we find is that if we can work with our schools and have them approach school as if it were achieving recovery goals and not academic goals, that actually makes a huge difference, because again, then they get 2 birds with 1 stone, where they're doing schoolwork as well as recovery, but they don't feel that academic pressure to achieve because they can't, because they don't have the cognitive stamina to be able to do so. And so that's usually how we approach the cognitive. And a few kids will do the formal speech and OT with executive function training. And then the vision rehab we'll use to address the specific visual symptoms and increase visual stamina. And so in this study, we looked at vestibular therapy, and what we found was that with these kids, actually, they're a more chronic cohort. As you can see, they were a month or more out from their injury, and then they started the PT later. But the vestibular physical therapy actually helped ameliorate their symptomatic issues with the visio-vestibular exam. In particular, were helpful with both general concussion symptoms, visio-vestibular symptoms, as well as the balance on the BESS evaluation, which you guys all know. But it didn't address the near point of convergence problems. And so again, a little hint that these symptoms are related, but different. And so then in this study that we looked at, what we found was that of the kids who had this receded near point of convergence in terms of seeming to manifest a real visual deficit, that some of those kids actually did get better on their own in that 4-week time frame. Another 41% resolved their near point of convergence issues with vestibular therapy, where there is a little bit of eye training that's done. But then there was that smaller 13% that really needed to go on and have vision rehab to have that be addressed. And so again, now we're starting to break down what are the types of kids potentially that may need slightly different approaches in terms of how we treat and manage them. And so then this is the slide with the aerobic exercise preventing persistent symptoms. And so again, we're interested in the fact that this aerobic exercise, we think, is targeting the autonomic nervous system, that system is dysregulated after concussion, and if it doesn't recover on its own, might benefit from aerobic exercise as a therapy. And then we are interested in potentially the eyes being a window into that, right? Because if the pupillary light reflex and monocular accommodation is related to the accommodative amplitude and your autonomic function, aerobic exercise might be a treatment for accommodative deficits, right? And so there's a little crosstalk there in your brain. And so then this is our guy, again, that you saw before his vestibular therapy. And then after his vestibular therapy, his balance is a lot better on our complex tandem gait. And so basically you see what we like about removing the visual compensation is the fact that basically when you have the visual input, you're able to compensate more for balance issues. When you remove that visual input, you're probably getting a little bit better sense of what your brain balance is like and not just your integrated, musculoskeletal and brain balance. And then this is our guy with the funky eye movements before his vision rehab. And then this is him after his vision rehab. And so again, I think that I don't know why it took us so long, and maybe it's just us. You may have landed on this earlier, but obviously there are systems in the brain that we can rehabilitate. And so even though concussion is the mildest form of mild traumatic brain injury, there may be approaches that we can try and use for our kids. The last little bit that I want to share with you is that we're doing some interesting stuff looking into physiological biomarkers in concussion. And this is functional near-infrared spectroscopy, which is essentially like a poor man's MRI. It gives you an idea of what the blood flow is in the brain given any particular activity the brain is doing. In this study, we had them essentially read the King-Devic test, where it's a rapid number naming test. They read it as quickly as they can. We can get even little kids as young as 7 or 8 to do this, wearing that optode. Our engineers on our team basically developed this calculation of neural efficiency, where essentially neural efficiency, the concept is that it's whatever your performance output is minus your efficiency plus the little conversion of the square root of 2. But the neural efficiency is on that diagonal where essentially your performance is equal to your effort. Like whatever your effort you're putting in, you're getting the exact same of performance out. And so that's a neural efficiency of 0. If you're more efficient, you're on the upper left quadrant. If you're less efficient, you're in the lower right quadrant. And what we found in our concussed kids was that basically our concussed kids were less efficient than their non-concussed adolescent counterparts. And so what we really liked about this study was that it basically validated that everything our kids have been telling us all along, that after concussion, they can do the things that they used to do, they just can't do it quite as quickly or as efficiently and as well. And so we were really thrilled to be able to back up what they're telling us, with some research and some science. So take home is that these vision and vestibular deficits are really common. Please look for them. And you can actually target some of your support and accommodations for academics and for activities and sports, accordingly. Active recovery is really where we want to go now, not passive wait and see. Targeted rehab strategies, I think, are really useful. And then keep an eye on potentially some new developments with some physiological markers that will be hopefully coming down the pike that will be helpful down the line. And so we have lots of resources on our website, and so please take a look. We also have a quarterly newsletter that I can also send a link for if you would like to sign up and hear more. This is my awesome team. I don't do it all by myself. And this is us at a Phillies game where it was earlier this year, and we actually won that one, not like the one that we lost in the World Series last couple weeks ago. And that's my email, and please reach out with any questions anytime. Thanks.